Good morning again. It's my privilege to introduce our next speaker, Dr. Kimberly Chang. She's a family physician and the Director of Human Trafficking and Healthcare Policy at Asian Health Services in Oakland, California. In this role, she serves as the Speaker of the House on the Executive Board of the National Association of Community Health Centers, as a commissioner appointed by President Biden to the President's Advisory Commission on Asian Americans, Native Hawaiians, and Pacific Islanders. She completed a Commonwealth Fund Minority Health Policy Fellowship at Harvard, and through her work there provided expert testimony to the U.S. Helsinki Commission on best practices in rescuing trafficking victims. She serves on the National Advisory Committee on the Sex Trafficking of Children and Youth in the United States and co-founded Heal Trafficking. Dr. Chang has been recognized for many awards and, as you can see, has quite the expertise on the topic of human trafficking. And we are so grateful to be able to hear her perspective on this matter here today. Dr. Chang.
Thank you. Thank you, everyone, for staying here with me. I really enjoyed waking up at 5 o'clock and listening to all the speakers, but it was worth it. It was worth it. So I appreciate the stellar panels that you put together, Dr. Teresa Smith, and I also appreciate Dr. Hawthorne Smith as well. Hawthorne, right? Yes. Okay, so I'm going to talk about the work that I do. I'm a family doc. You folks are mostly ER, I think. So I'm going to try to make it applicable to you. What we should do within our clinical practice, and then extending out. You've heard a lot from the previous speakers about the role of advocacy and policy, and really emphasizing that we need to be advocates for policies that increase access to systems of care and protection for our patients. So I don't have any financial disclosures. And then we heard a lot about listening from many of the previous speakers. So I just want to show this here. This is the character for ting in Chinese, in Mandarin, which is to listen. And I want to just show the character, because when we listen to our patients, when we listen to our communities, if you're in public health, if we listen to our clients, what we really want to do is listen with our ears, our eyes, our maximum focus, our brains, giving our full respect and our attention as we would if it were a king, and with our hearts. And so I'm going to be sharing a lot of stories of patients that I've seen in my practice. I've been at Asian Health Services for 22 to 23 years now, right after residency, and been there this whole time. Just want to bring their voices into the conversation here today. I've been raped 2 times, then I've been tortured by 2 guys in 2 days. These are the words of a patient of mine who understood her role and her place in this world. So I'm tired, girls dying, people catching AIDS. So I don't want to be doing it, because that can be me. These are the words of a patient of mine who understood what her future holds. It's like if you die, get murdered or something, all it is they have another girl taking their place. That's all it is. These are the words of a patient of mine who understood how much her life mattered. And so what is human trafficking? So human trafficking, by definition, in the legislative definition, is a crime, is defined as a crime. And it was first defined in federal legislation in the Victims of Trafficking and Violence Protection Act of 2000, the TVPA, as it is known. So what is it? Human trafficking is 2 parts. One, severe forms of sex trafficking, which is a commercial sex act through force, fraud, or coercion, in which a person induced to perform that act, or a commercial sex act in which the person induced to perform that act is not yet 18 years old. So that applied to the 3 patients that I just shared their stories with you. Or it's number 2, labor trafficking, which is the recruitment, harboring, transportation, provision, or obtaining of a person for labor or services through the use of force, fraud, or coercion for the purpose of involuntary servitude, peonage, debt bondage, or slavery. Now, this is important because when things are defined legislatively as a crime, it then has enforcement mechanism, and hopefully it has redress mechanisms or resources given. But let me ask you this, as healthcare providers, are we criminal justice investigators? Are we able to make the determination that one of our patients is a victim of a crime? And I would submit to you that no, we are not. That is not my job. I am not a criminal justice investigator. I am not in law enforcement. My job is to provide the best care that I can to the person in front of me. And so when we think about it this way, oftentimes when I do this talk or versions of this talk, healthcare providers ask, when do we call law enforcement? Well, no, that's not our first, that often shouldn't be our first reaction, because we have to look at the patients and the spectrum of experiences and what are their needs. We heard a lot about agency. We heard a lot about what do the patients want? What do the patients need? We heard a lot about barriers to trust. And so when I talk about human trafficking in healthcare setting, I talk about the spectrum of experiences. And so let's think about it for labor trafficking. Labor trafficking is at the center, where it's that criminal, very specific criminal justice legislative definition. And then there's labor violations, which are a legal term used when employers violate federal, state, or municipal laws related to worker treatment, workplace safety, or record-keeping requirements. And then there's the broader category of labor exploitation. This is not, a legal term. And in fact, not all forms of labor exploitation are illegal. And so we'll get into that. If you really want to get into prevention efforts, you've heard a lot about the social determinants of health. Well, really, these are policy and political determinants of health. And so then we're going to get into that later in this presentation. So for us in healthcare, we're looking at labor exploitation more broadly. And then for sex trafficking, again, the broader category of sexual violence. You heard from Dr. Hawthorne Smith about sexual violence and torture and used in that way. Maybe it wasn't sex trafficking with that qualifying for that criminal legislative definition. Sexual exploitation is a little bit broader, where it's the actual or attempted abuse of a position of vulnerability, power, or trust for sexual purposes. And then sexual violence, which is a whole a broader category. Now, this is important because our patients are not going to tell us, I'm a victim of human trafficking, I'm a victim of sexual exploitation, I'm a victim of sexual violence. They're going to tell us about their experiences and our history and the review. And when we talk to them about their the context of where they work, live, play. Okay, so here's a patient, BK. BK is a patient of mine who came in about 2008. She was about 14 or 15. She came into the teen clinic. We had been seeing her off and on for our reproductive health care teen clinic in California. And she came in that night very sick. We knew that she was being commercially sexually exploited in Oakland, in the streets of Oakland. And she came in that night very sick. She had a high fever. She was tachycardic, rashes all over her body, swollen joints. She could barely walk. She lost 30 pounds over 3 months. And I told her, I said, oh my gosh, I don't know. You might have one of those, the first speaker who talked an infectious disease or something that we can't treat in the outpatient setting. I need to send you to the hospital. So I told her that, and she told me, I would rather die than go back to jail. I didn't quite understand. What do you mean? I'm sending you to the hospital to save, to help you. And what it turns out, what happened was, on a previous hospitalization for a miscarriage, she went to the emergency department, she got treated, and because she was an unaccompanied minor at the county hospital, she was discharged to jail because there was a bench warrant for her arrest on charges of solicitation or prostitution. This is back in 2008. So she didn't go to the ER that night. And I really, she didn't go to the ER that night. So that was really a turning point for me. The Trafficking Victims Protection Act started in 2000. This was in 2008. I actually did not know about the federal criminal justice legislation, and the California state laws didn't match that. So these kids were being charged with solicitation and prostitution and being prosecuted. And so she didn't go to the ER that night. So you want to know what happened to her? Yes? Nods. Okay, you have to keep listening because I'll tell you at the end. Thank you. I always get chuckles, but you're all on mute, so I can hear it. Okay, so is it our role in healthcare? Yes, it is our role in healthcare to be interfacing in this arena. A study one study showed that while being trafficked, almost 88% of the trafficked victims had encountered a healthcare provider, and 57% had visited a clinic, and none were identified as being trafficked. And then who do they meet? This is a study from a good friend of mine, that Dr. Teresa Smith also knows, Dr. McKinney Chisholm Stringer, who's an ER doc in New York as well, who's doing right now a lot of policy-based reparations work. So you should look into her work, because everything that we're talking about today, she's looking at in terms of reparations, in terms of policy. Okay, so who did they meet? Look, emergency department, 55%. For me, primary care, 44%, or pediatrician, 3.4%. Dentist, we have dental clinics in community health centers where I work. OBGYN, 26%. And so really there's a lot of opportunity, I would say missed opportunity in the past, but now future opportunities and possibilities for us to intervene and to help these patients who are being exploited and trafficked and harmed. So there are similar intersectional dynamics of intimate partner violence and human trafficking. I bring this up because what is intimate partner violence? It's a pattern of power and control. Same thing with exploitation and human trafficking. And so one of these studies here, this was a study of youth, a small study, but who were the traffickers? Well, look on the key here: immediate family, boyfriends, friends of family, employers. So a lot of interpersonal violence there. And then the similar dynamics with the physical and sexual violence, restrictions on freedom of movement and control, isolation, financial control, intimidation, fear. Dr. Hawthorne Smith talked about a lot of fear and intimidation and control. And then very importantly for healthcare, the fostering of drug and alcohol dependencies for that control. It's very important for how we're going to treat and what our patients might need. So the health impacts, I'm not going to go over this too much, but they're basically the same. It's about trauma, it's about injuries, it's about forced exposures, it's about reproductive health. Some of the very important health impacts that I do want to highlight, though, are the traumatic brain injuries and strangulations, because these don't often show up physically when we see them in our practice. Maybe for you folks in ER, but for me in primary care, the traumatic brain injuries and strangulations don't show up. They don't show up, right? Because it happens and then they come to the clinic. There might not be any physical signs. And so it comes out for me in the history taking. I did have a patient who I was kind of confused about why she was acting so weird. She was an immigrant from China. And just as I got to know her, and on one visit, her daughter came with her, I did my universal education about intimate partner violence. It turned out that she did have a lot of domestic violence in China and had a lot of strangulation and head injuries. And so, the daughter told me that, and then I had a fuller understanding of what was going on with her and her interactions with healthcare. So that's something that you should be aware of in the back of your mind always. And I think all of you ER physicians probably understand this better than us in primary care. And so behavioral health, Dr. Hawthorne Smith talked a lot about this. I won't belabor the point, but that intersection with trauma and exploitation, trafficking, and interpersonal violence is very real. So another one, reproductive and sexual coercion. Now, as choices and autonomy for women are narrowed through legislation, reproductive and sexual coercion in terms of intimate partner violence as well as sexual exploitation becomes even worse. These, controlling someone's reproductive choices and to maintain power and control in a relationship or in a capitalistic relationship or is very real and something that we should be attuned to when we're seeing our patients for these issues. Just wanted to really emphasize that. Okay, so what do the studies show? Studies show that healthcare providers do make a difference when we talk to patients about their experiences. And I bring this up because what I'm going to present to you next is a different framework other than screening. So when we talk to patients and we have conversations about their experiences, they are 4 times more likely to use an intervention and pursue those linkages to care that many of our other speakers today have talked about. And so this is very important. I'm going to talk to you now a little bit about something you can do within your practice, possibly. I'm not sure for ER how feasible it can be, but I think this is a different framework from just relying on screening only. Because when we rely on screening for exploitation or interpersonal violence, what happens is we ask the question, if the patient answers yes and there is a disclosure, okay, then we get the linkage to care, the information, the services, referrals, the help and assistance. If they answer no, they get nothing, right? We move on to the next patient because we're so busy. We have however many other patients waiting for us. And so what I propose to you and what the research is showing and what the work that I do with Futures Without Violence in training healthcare professionals and domestic violence advocates and other allied health professionals across the country is that we should always think about shifting from screening to universal education. And so when we think about screening, this is, I mean, I'm guilty of this as well. I'm guilty of this. We're sitting at the computer, typing our notes. No one's hurting you at home, right? Because I have to check that box. And the partner is sitting right next to the patient, or the employer maybe has brought them in for their immigrant patient. They brought them in for a physical exam. Okay, within the last year, has he ever hit or hurt you? And the patient's behind me. My computer is just mounted to the wall, so I can't really turn around and talk to the patient at the same time. And my back is to the patient. Or I'm really sorry, I have to ask these questions. It's just a requirement of our ER or of our hospital or of our clinic. And then I ask them these questions. But what does that say? What is the implicit message? Oh, this is something that is not important. But we don't know what's going on in that person's life, right? And so it's almost dismissing it before you even get a chance to talk to the patient. Okay, so what I propose, if you can, is CUES. CUES is an evidence-based intervention. This is a safety card. It is from the organization that I work with, that I partner with, Futures Without Violence. They've been doing a lot of intimate partner violence and violence work in the healthcare setting for decades. And while this is really more tailored toward intimate partner violence, you heard earlier that there is the intersection between exploitation and intimate interpersonal violence. They do also have some cards, particularly for youth, around exploitation and trafficking. But what does Q stand for? Q stands for confidentiality, universal education, and empowerment and support. So it is based on a brochure, this safety card. It's a wallet-shaped card. It's tri-folded. And what it does is it creates a linkage between the experiences that a person is having and healthy relationships and unhealthy relationships and how it impacts their health. So it sort of normalizes that this is something that happens. We know that 1 out of 2 women, 2 out of 5 men, and 1 out of 3 people of non-binary trans experience over their lifetimes experience intimate partner violence. And so this is very important. So we recommend doing the universal education before you do your screening so that it opens up the conversation for patients to share their experiences. We recommend seeing the patient alone. That's the confidentiality part, disclosing the limits of confidentiality. When do you have to call, make a mandated report? When do you have to break confidentiality? Universal education and empowerment is normalizing the activity, normalizing the experiences that they may be going through. I give 2 of these cards to all of my patients in case it's ever an issue for you, because relationships can change. And also, so you can have the information and you can give it to your friends or your family, because this is such a common issue. Patients often take those cards because they say, oh yeah, I have somebody in mind. I'm going to give this to this person or that person. And so it taps into altruism, because oftentimes people are willing or able to help somebody else before they are willing or able to help themselves. or make the understanding that they might need that help. And then you make the card, you open it, you do a quick review. It talks about healthy and safe relationships, ones that aren't, and how they can affect your health, situations where youth or people are made to do things they don't want to, and tips so you don't feel alone. And then on the back, there's support. These cards can be localized to your community if you contact Futures Without Violence, their domestic violence resource center. And it has a lot of national resources. And if you localize it with Futures, or you localize it yourself, you can put your local resources on there. I think that would be particularly important in the ER setting because you have sometimes only one shot to be with your patient. So you want to get those resources out, even if somebody does not disclose, because there are many barriers to disclosure. So this is the example of the script. And the reminder that disclosure is not the goal for us with universal education. And then you can do your screening after you have that open-ended conversation and give out these resources. Disclosure is not the goal, and disclosures do happen. So what do patients want us to say or how to be? When I do this training, I just did this in-service for my clinic 2 weeks ago, or actually last week, I can't remember. And you know, they wanted scripts. They wanted to know, well, they don't feel comfortable. They want help on how do you make that, because it's hard. You heard we need to have this rescue boat, right? We need to have the rescue boat, and we have to understand how to take care of ourselves. And giving these scripts when you're absorbing a lot of this trauma vicariously is often helpful. So be non-judgmental, listen, offer support information, don't push for a disclosure. And these are one-line scripts, very simple, that you could say. I believe you. I'm so sorry this is happening to you. Thank you for sharing this. I don't even know what to say right now, but I'm so glad you told me. You don't deserve this. Thank you for telling me. You're not alone. It's not your fault. You get to choose what you do next. Okay? So these are very simple things that help to build connection, to help try to get that trust, and to just make sure that the system, as the patients leave the ER or leave our clinic and go forth into the future with other healthcare providers, that they might realize that the healthcare system is somewhere that they can get help. Here are some hotlines. I'm just going to leave this here. I think Dr. Smith will send out a PDF later of the slide deck, I think, and so you can have those available. Okay, so now I'm going to shift into a little bit to, that was what you can do within your clinic or hospital walls. Now I'm going to shift into a little bit about prevention or advocacy or policy if you want. So let me ask you this. Who is vulnerable to exploitation and human trafficking? So who's invisible or harder to see in your community? I don't know if anyone wants to type things in the chat for this part, and you're welcome to. So who's invisible or harder to see in your community? And I would suggest to you, we've heard this throughout the course of the morning, that people who are marginalized, who are oppressed, or who are disenfranchised are often the ones who are harder to see and are vulnerable to, vulnerable for the social determinants of health. So here's a non-exhaustive list, but these are some of the examples that that come to mind very quickly. I see somebody put something in the chat. People without resources, life resources rely on others, people at legal risk. Yeah, marginalized communities. Thank you, Dana. Dana works with me. Okay, so who's so this is health basically, right? So, but let me ask you this. This is actually a better question. How are people made vulnerable to being exploited? How do we, as a society at large, create vulnerabilities for people? And what are the historical roots of human trafficking? And luckily, there is a textbook. Again, Dr. McKinney Chisholm Stricker, one of you, ER doc. I love Dr. Chisholm Stricker. She's so amazing. Okay, so this textbook, what are the roots of human trafficking? It's a pretty big textbook, but let me just give you the upshot. isms and phobias create conditions for vulnerability and precarity through policy and practice, right? So we know this. We know this on a like just a it's just normalized throughout our society that these kinds of isms and phobias create structural dislocations for people, and the people on the wrong side of that structure get left out. And so what are those isms and phobias? Capitalism, racism, xenophobia. Well, I'll get into that most for this session today, since it is on immigrant health, sexism, and homotransphobia. These are just some of them. And they underlie the way policies have been made historically in our country. Now, capitalism in and of itself is not a bad thing. It's how we structure our society and our economics. And it does exactly what it's meant to do, which is to concentrate profit and wealth, right? That's what it's meant to do. And that's how we have what we have put value in our society. And so let's get into it a little bit. So capitalism from the inception, this is story time, history story time. So capitalism has always been a driving force in our country. We know this. This is fact, that exploitation and slavery and the commodification of human beings for profit has financed every single modern U.S. institution in our history, right? And so we know that is what our country has been based on. But what does modern day capitalism and exploitation look like? So when we think about these kinds of differential categories of workers, work visas, workers with lesser rights or benefits, the prison industries, basically this is basically slavery in the prison industries. I mean, they get like a cent an hour or something, very, very little. And then gig workers, when we talk about gig workers, well, why do we put that category on it, right? And so there's no retirement in this job gig workers say. Workers who they don't consider employees, they struggle to put away savings while making small amounts for delivery and other tasks. And so, illegal, yes, but exploitation, yes. All right, so that's modern day. Let's look at the agricultural industry. And this is just a framework of how things are structured. Look, labor here is labeled under commodities and expenses, things to be used up. I see a chat to the admin. Can we put the messages of the card in the bathrooms in the wing? Okay, thanks, Jennifer. All right. All right, so, and then child labor in agriculture. Let's think about this. U.S. federal child labor law for hazardous employment in non-agricultural work is 18 years old. In agricultural work for U.S. federal law, it's 16 years old. And I did a presentation in Iowa. And so in Iowa, there's no limit on hazardous employment. And think about who does agricultural work in our country on the whole. I'm not talking about the farm owners or the agricultural landowners. I'm talking about who's doing the actual labor in the fields. Just think about that for a second. And then here we have multiple headlines. Lawmakers proposing loosening child labor laws to fill worker shortage. Iowa governor signing loosening child labor laws. The big expose from the New York Times, which was great. You should follow this writer if you don't already, since you folks are in New York, Hannah Dreyer, really shining a light and exposing the migrant children who are working in factories, fields, manufacturing all across the United States, alone, exploited. And the restaurant industry having a child labor problem. I see I have a couple other chats. Oh, thank you, Dana. Okay. All right, so another patient of mine, this was OT. OT was she was about 20, in mid-20s. or early 20s. She was G1 T0, so her first pregnancy. She had a lot of morning sickness, so she was coming into the clinic to see me almost every 3 days for dizziness, dehydration, because she was just throwing up all the time. She worked in a local restaurant and throwing up, throwing up, throwing up. So I said, "Oh my gosh!" And she said she's so dizzy she can't work. I said, "All right, can I write her a note for work?" I wrote her a note for work. Please excuse her. She can't work right now. She's very dizzy. Comes back 3 days later for IV fluids, and she's a bit distraught. She says, "Well, my employer, he's mad. He fired me because he said if I can't work, then I don't have a job." I said, "Oh, I don't know much about labor law, but I do know that pregnancy is a protected class and you can't be fired for being pregnant." So I wrote another note. I said, "Hey, employer, this is not right. You can't do this. She's pregnant. This is, she's sick. You can't fire her." She comes back 3 days later, very, very sick, with the dehydration, IV fluids, everything. And then she says, "Well, now he's really mad. And he said he's going to fire me, my husband, my brother-in-law, and all the Chin employees at the restaurant." So she was a refugee from Burma. And this is what she came back to tell me. I said, "Oh my God, that that's terrible." And so we hooked her up with our Asian Pacific Islander Legal Outreach, which is a civil legal aid organization. And she got in touch with them, and she came back later. She said, "Oh, it's fine now. It's fine now." She didn't ever want to talk about it ever again. I go away to fellowship in 2014 to Harvard. I come back. I'm working at the clinic. A few years later, big news article in the papers about this restaurant, a group of restaurants that they have been fined for multi-million-dollar fines for a lot of wage and labor violations. And so, I'm thinking, it's good that we are able to do that linkages because this matters. This matters when we connect our patients to civil legal aid and all of that. All right. So racism, there's no biological basis for the classification of people based on race, and race is a social construct. And we also know that racism constructs social institutions, policies, practices, and systems. And we know that capitalism in its earliest forms were inextricably intertwined with racism. And so, the redlining, restrictive housing covenants, discriminatory bank lending, forced boarding schools, Jim Crow and segregationist laws, Japanese internment camps, selective application of eminent domain in the construction of urbanization products, all of these things harmed Black and Brown and immigrant communities. And don't just take it from me, even the federal government, the U.S. Department of State, acknowledges the historical and ongoing harm with the connections between systemic racism and human trafficking. This is our federal government. Human traffickers disproportionately target those in positions of socioeconomic or political vulnerability due to discriminatory policies, often people of color or racial minority. Traffickers exploit to compel victims in sex trafficking or forced labor because of discriminatory government policies and private practices that create disparities in access to economic means or opportunities. Keeping certain racial communities from attaining financial stability, building generational wealth, gives traffickers ample opportunity to provide alternatives. And so there's this connection. We know this implicitly, but I want to call it out explicitly because that is when we can actually target specific policies and advocate on policies that can decrease the precarity of our patients. I won't belabor this. We just talked about it. Just wanted to list it out. All right, so DH. DH is another patient of mine. He was a transitional age youth. He was 18 now, coming to the teen clinic. So he's an adult now, but transitional age. He was in foster care. He's half Vietnamese and half African American, half Vietnamese American, half African American. Both his parents had died, and he had been in foster care. And so just during the course of history taking and talking to him about his experiences, I asked him about trading sex for anything of value, in the context of our conversations, and this is how he presented to me. He basically said, "Yeah, I did it because she bought me some video games I wanted." So still developmentally, a teenager, and being exploited by an adult woman, right? And so, and it's not right. It's not right, and that is trauma to him as well. But that's how he presented. Did somebody have a question? No. Okay. All right. So xenophobia and immigration policies. So just as capitalism and racism are intertwined, so too are racism and exclusionary immigration policies. So historically, these exclusionary immigration policies rooted in racial animus thought explicitly not only to prevent migrant peoples of color from entering the United States, but also to limit their access to full or partial rights if and once they arrived. The racialization rendered migrant workers of color doubly vulnerable to commodification and exploitation. It separated them ideologically from the labor they produced and also denied them claims to social membership. So just look at the terms that used in the past and currently that create or created differential classes of people with differential access to systems of care and protection based entirely on exclusion. The people who are exclusion of the people who are producing the very sought after labor. So, people of color were wanted for our labor, but we weren't wanted for our humanity. So historically and in the modern day, immigrants are needed for labor. That is true to this day as well. So I work at Asian Health Services. I'm on President Biden's Advisory Commission on Asian Americans, Native Hawaiians, and Pacific Islanders. This is my area of expertise. So I'm going to talk about exclusionary policies as it pertains to Asian Americans, Native Hawaiians, and Pacific Islanders. But you will see, if you listen closely, correlations with current day policies. Okay, so the very first time the border was closed was in 1875, and this was the Page Act, and it excluded Oriental women from coming to the United States because we, people who look like me, were deemed to be public health hazards because we were all assumed to be prostitutes, sex workers. And so excluded, written into legislation, the first time in the United States. In 1882, the Chinese Exclusion Act was enacted. This was a time of growing labor discord between Chinese laborers who are coming in to build, most famously, the railroads, but also filling the labor shortage as slavery had been outlawed. So they still needed labor. Who did they get it from? Chinese workers. So they excluded all Chinese workers, all Chinese from becoming citizens here. And then 1888 to 1892, this is the first time the US federal government starts requiring people who are Chinese to carry photo identification. First time. If you didn't have it, you could be immediately arrested, held in detention indefinitely, and immediately deported. So the immediate deportation has since been fallen by the Supreme Court, but the indefinite detention is still upheld, and that's where you get some of these camps, detention camps at the border currently to this day. But so here we have restrictions in the United States. In 1898, there was the illegal annexation of the Hawaiian Kingdom. In 1907 to 1908, Japan was a rising imperial power. The United States didn't want to risk war. And so they said, okay, you're okay for now. You can sort of come into the United States, but you have to restrict it on the back end, Japan. You restrict your immigration to the United States, and that's our gentleman's agreement. In 1917, the Immigration Act of 1917, well, this happened. So everything in the purple lines, every single person who resided within these purple lines was barred from coming to the United States. You can see Japan and Korea, they were kind of excluded because of that gentleman's agreement. And then here in yellow, that's the Philippines. Well, the Philippines was a territory at the time, and so the Philippine nationals were called nationals, and they were able to come to the United States, but they weren't citizens. They just come and be in the United States. So they were kind of carved out. But you can see everything. Asia and Pacific Islanders were excluded, and so that's basically there. 1924, the United States was not happy with Japan's ability to restrict migration, and so they said, and the United States was not getting was getting more xenophobic, and so at that point they enacted legislation to bar Japanese and Koreans from coming to the United States. And in 1933, what happened? Well, Philippines independence happened. And so once they became an independent nation, they were no longer a territory. And so now the Filipinos were excluded. And we all know what happened in December 7th, 1941. Pearl Harbor was bombed. I'm from Hawaii. My grandparents were working at Pearl Harbor, civilians at the time. And 1942, in reaction, Executive Order 9066 to put Japanese American citizens into internment camps. So if you look at this, you know, this is a slow roll of exclusionary policies towards Asian Americans, Native Hawaiians, and Pacific Islanders. And you can see that it continued through other exclusions like redlining, racial housing covenants that also pertain to African Americans. And so when we see this, a lot of these kinds of policies are being enacted today, and we have to be vigilant. Why? Because access to systems and care and protection, differential access, creates conditions for precarity and vulnerability, leading to exploitation and then human suffering. So SD was a patient of mine. She was a Chinese immigrant in the South Bay of California. She had a known trafficking case that was being worked with the district attorneys in Santa Clara County. But she resided in Alameda County, which is Oakland, where I live and work. Based off of Medicaid and Medi-Cal insurance, you have to receive care in the county you reside in. So I got a call from the case manager. She has an open human trafficking case here in our county, but she lives there. Can we transfer her care to you? So she can, I said, sure. What's going on? Does she need to be seen right away? No, I think she's okay. She doesn't have any urgent issues, but she could be malnourished. I said, oh, why do you think that? Case manager says, well, she has ramen stuffed up to the ceiling in her apartment, and that's all she's eating. I said, oh, why is that? Tell me more. And she says, well, she thinks that she's going to be poisoned, and so she won't eat anything else except this ramen. She thinks everyone outside is trying to poison her. And so, I mean, it could be true with the traffickers, but she was also having a lot of substance use issues from the trafficking situation. And it sounded like she was having some delusions and paranoid issues. So we got her connected with our specialty mental health psychiatry intake. All right, so sexism, another ism. I don't know if you folks remember this, a few years ago, 3 years ago in Atlanta, the shootings at the spa workers. Experts say following an antiquated playbook does little to protect women, often exploited by a billion-dollar industry propelled by a toxic mix of racism, misogyny, and fetishization. Arresting low-level female workers, they say, further stigmatizes a population at risk of violence and trafficking. The suspect told law enforcement officials he had frequented 2 of the spas, describing them as temptations for his sex addiction that he needed to eliminate. So sexism creates vulnerabilities for all genders. You heard about my patient DH, who was never screened or never talked to about what was going on in his situation. Unequal pay, less advancement opportunities for women, less financial independence, the politicization of women's and girls' bodies and sexuality, disparate criminal justice responses to sexual violence for men and boys, hiding. These gender stereotypes hide and invisibilize male victims and survivors of sexual violence. and trafficking. And again, for non-binary and trans, invisibilized and also targeted right now, currently through policies. Oh, I talked about DH already. Okay, I'm gonna skip this one. All right, homotransphobia. This is very clear that there are policies that exclude LGBTQ communities. It was only in 1973 that the DSM removed homosexuality as a mental health disorder. The World Health Organization only removed this classification in 1992. Homosexual acts were criminalized in the United States until 2003. And there's continued systemic oppression via denial of equal rights in the areas of adoption, military participation, health insurance, support for gender affirmation, denial of government-issued identification, and outright legislative bans targeting this community. And so when we think about policies, who's included, who's excluded, who has access, who doesn't, this creates those vulnerabilities. The policy can be a weapon or it can be salve. And BK, so now we're coming to the end. She was the 15-year-old, 14-year-old who came in to see me very sick, didn't go to the hospital that night. Okay, so she didn't go. I freaked out. Our team violated every single HIPAA. We called everyone we knew in the community who knew her to try to find where she went, and we found her. The next day, went to her. Our case manager, youth program folks went to her, talked to her a couple hours, convinced her to go to the hospital, drove her there, took her to the ER. She got admitted for 2 months, and she survived. Great outcome. She survived. Very sick, but she survived. And on discharge, after she got stable on her meds, on discharge, guess what? She was discharged to the county jail. And then the next day, she actually bounced back to the hospital. Why? Because the jail didn't give her the medication she needed. So, a lot of dislocations here in this, but she did survive. But the fact of the matter is she still was discharged to county jail. So let's talk about some of the wins since that time. That was in 2008. So some of this time, you heard a lot in my bio about some of the advocacy and policy work that I've done. And this is all in a movement with a lot of other folks. But now in California, minors can no longer be arrested. And I think this mirrors New York. They cannot be arrested or prosecuted for prostitution or solicitation. This happened in, I think, 2014. California law mirrored the Trafficking Victims Protection Act law. Diversion to safe harbor programs if arrested for other acts and found to be sexually exploited. The commercial sexual exploitation of a child became defined as child abuse, and then mandated that the child welfare system develop the policies, protocols, procedures to care for commercially sexually exploited children. So that was the legislative policy win in California, and here's some national wins in healthcare policy. Here I am talking to you folks in emergency department about human trafficking. So it is increasingly being recognized and addressed in the healthcare setting. There were ICD-10 codes released in 2020. You should look those up. For us specifically, in community health centers, we are required to report to the federal government measurements on exploitation and intimate partner violence. Futures Without Violence, that new national training and technical assistance program that I work with, that was created in 2020. And then there have been pilot demonstration projects for medical legal partnerships on human trafficking interface from the Administration for Children and Families. We're still working on a lot of other healthcare policy, and it's a slow process. Policy is slow, but we have time, and that's what we use our life energy for. And we spend time doing things because we want outcomes. And so, like many of the other presenters today, I really implore you that as we care for our patients, we must also be advocates for policies that increase access to systems of care and protection. We don't just exist within our four walls of our clinic or our hospital or ER. We exist like our patients in community, and that is our charge, to use our experience to advocate for these kinds of policies and access. So that's organizing, advocacy, and policy. We're going to take exclusion and inequity, kick it to the curb, or inclusion and equity. That's my mom and my grandma when we were doing a public charge rural movement initiative. That Unite campaign was about one nation. So that successfully got changed under the Biden administration. But anyway, so that's it. That's all I got for you. I think I finished right on time. And I'm going to stop sharing my screen. Thank you.
Thank you very much, Dr. Chang. Can we give a virtual round of applause for Dr. Chang? That was absolutely fantastic. I have to say, I've been inspired by all the speakers thus far and have received practice changing information. So this has been absolutely wonderful.